Good morning, everybody. My name is Linda Koenig. I am a senior advisor in the Division of HIV Prevention at CDC. I'm co-leading this presentation, this panel today with my colleague, Dr. Pam Klein from HRSA. And we will be starting, we were each given about 5 minutes to address some questions about the role of our agencies in translating research to practice and our funding implementing organizations and where we are at and what's needed from our federal agency perspectives. And then after each of us have a chance to give you our 5 minutes, you'll be hearing from our esteemed panelists. The first will be Dr. Reva Datar, who is a postdoctoral fellow in HIV epidemiology and prevention at the Johns Hopkins Bloomberg School of Public Health. Our next speaker you met previously, Mario Perez. Mr. Perez serves as the director of the Division of HIV and STD Prevention, STD programs at the Los Angeles County Department of Public Health. And then finally, Mr. Leroy Blea, I hope I pronounced that right. Leroy is the Ending the Epidemics Manager at the California Department of Public Health Office of AIDS. So we'll be getting a perspective on communities, local health departments, and state health departments. So let me start just for a few minutes talking a little bit about CDC. Historically, CDC has had a large role in translation. We've been identifying evidence-based HIV prevention interventions and documenting them in our compendium since 1996. And for about 20 years, through a process called REP and Debbie, some of you may remember that, we translated, we packaged, we trained, and we disseminated those interventions to our implementing partners. And for us, that is the health departments and the CBOs. A lot of people have asked me why we transitioned away from that model, so I wanted to take just a few minutes to mention that. We transitioned away from this research to practice model in 2013 because, as you know, at that time, a lot of new biomedical prevention options became available. PrEP, we knew that treatment was effective as prevention. We had rapid testing and self-testing. In addition, we were conducting a lot of resource allocation modeling, and those models were telling us the best ways to cost-effectively avert new infections, and they were telling us to focus in more on just a smaller, limited focus of interventions. And then finally, new public health strategies were also becoming available in which we were investing. Some of those include data to care, which is a process to use surveillance and clinical data to identify people who have fallen out of HIV care, and using staff members to locate them and find them and bring them back to care. And other things like patient navigation, which were proving very important for helping people stay in care. So we were developing training programs for those. So where are we now? We are still publishing the compendium if you haven't looked at it for a while. It's grown quite a bit. We have 5 chapters, and it's evolved to match the evolving HIV science. So in addition to the original sex and drug risk behaviors, we focus in on HIV testing. We have interventions focused on all aspects of the continuum of prevention and treatment care, linkage, retention, re-engagement, adherence to ART, uptake and persistence of PrEP, and we also have a chapter on structural interventions, and you can search that compendium if you go to our website. But in terms of translation, a key thing we've realized is with so many options, prioritization is critical. And today we have actually restarted the pipeline of translation of some interventions. Internally, we have a new research to practice model and processes within our division to determine what is most needed, what will be most potentially helpful in the field. We are still using the compendium as our way of identifying interventions that at least we know have some evidence of efficacy, evidence-based interventions, evidence-informed interventions. But we're using implementation science and factors that we drew from various paradigms such as RE-AIM and others to, I think I'll say, best guess what will have the greatest use, reach, and impact, particularly on health equity in the field. And I say best guess because we have to start with a research study and move from there. So we look at the study, but we also talk to the research investigators, and then we have a cadre of SMEs who help us identify which ones are most likely to reach and impact the outcomes that we want. The main limitation we have right now is funding. We do have some new interventions that we're moving forward. They're in the pipeline, but we can do one, maybe two a year. So funding is certainly a limitation for us. And the other thing I wanted to mention is a lot of the new and novel interventions that have great promise are digital. So e-health, m-health, apps, web-based counseling, things like that, those all require new platforms. This is not a package and a kit that we could just train people on. We need a new platform. We need new funding mechanisms to support these kind of tools, and we need new technical assistance for digital health interventions. We are currently exploring those options. It may look like there's nothing yet, but it's a little complicated, but we really think those are going to be very important. The last thing I wanted to mention is thinking about sustainability. So I mentioned that we have a process to look at which interventions we might prioritize. One of those factors that we look at is, are there tools available for translation? So if there's, for example, you have a curriculum and there isn't like a training manual, we'll have to fund a contract to develop that training manual. The more tools are available at the start, the easier, the more cost effectively we could potentially pick it up and move it out to our implementing partners. And finally, I wanted to end by saying that if possible, it's helpful to think about who would be supporting this intervention, and by supporting, I mean paying for this intervention, after the research trial or the implementation study ends. So I mentioned that we fund the health departments across the country. I want to give an example of thinking about, would the health department want to continue a particular intervention with their regular prevention funds that they receive after an intervention study is completed? In 2021, we funded a project called Implementation Research to accelerate impact of health department-delivered HIV prevention activities. And the one thing I want to say about this, at the start, we had this idea that we wanted two things at least. One, we wanted full partnership between the researcher and the health department co-lead. And again, not that signing an MOU is bad, but we wanted more than just signing off on the MOU. So somebody who could truly partner with the researcher, and we wanted them to be answering questions that the health department needed answered and the health department wanted to be answered. And that's just one example of how to think about who would pick this intervention up after the research study is done. So we're starting to think about that, and we hope to be able to move more interventions out to the field soon. So with that, I thank you, and I'm going to turn it over to my colleague, Dr. Pam Klein.
Good morning, everyone. None of you saw that. It's always my biggest fear that I'm going to trip on something walking up to a podium, and you all got to witness that. So wonderful. Good morning, everyone. Thank you again so much for having me. I'm here on behalf of HRSA and also my colleague, Dr. Dimitrios Tsichopoulos, who many of you know. He's the implementation science team lead at HRSA in the HIV/AIDS Bureau, and unfortunately, he couldn't be here today, so get me instead. So HRSA has been translating research for practice for decades. Through our SPINs, or Special Projects of National Significance initiatives, we have focused on developing and identifying new strategies to reduce disparities and improving outcomes for people with HIV. And in the last 10 years, we've increasingly leaned into implementation science. In 2020, we published a HAB-IS framework, HAB, HIV/AIDS Bureau, again, acronyms, which describes the way that we have taken insights from implementation science to create a scaffold framework upon which more detailed implementation plans and evaluation frameworks for specific initiatives are built. So the framework calls upon all of our SPINS initiatives to not only give equal weight to how implementation happens and what is being implemented, but also to measure each of those systematically to generate knowledge that's generalizable beyond the single initiative. And this was conceptualized in collaboration with the Federal Implementation Science Workgroup, of which many members are here in the room today. And although we refer to our work in this area as our IS work, what we really mean is our implementation and dissemination science studies. So our current portfolio includes implementation projects, or projects where we identify or support development of innovative interventions in key focus areas where we see persistent disparities. So we have our Sure Housing Initiative, our 2IS initiative that has many priority population focus areas, and also an initiative on people who are aging with HIV, among many others. And we also have several projects focused on dissemination. We've made a great investment in the development of dissemination products that come out of these implementation studies. And we're really doubling down on dissemination to increase the reach, use, and impact of these products. So one way we're doing this is through the Best Practices compilation, which is housed on Target HIV. The Best Practices compilation is a hub for knowledge sharing across the HIV care and service community. It's a place to gather and share established and emerging approaches to improve care and services for people with HIV. And it is searchable, and you can also filter by lots of different parameters to get information, guidance, and resources to support replication. Currently, there are 95 approaches on the Best Practices compilation. And we also have a project that I mentioned briefly yesterday during the Q&A, the Rapid Uptake of Disseminated Interventions, what we call RUDI. And in RUDI, we're asking our stakeholders what products work for them and where they usually find them. And we're going to use the results of this project to guide our dissemination approach into the future. So a lot of this is in our SPINS portfolio, but we apply this approach across the Ryan White program, including in our EHE funding. So my call to action for all of you is please share your approaches on best practices. If you see something great, nominate it and search it. Take a look at it and give us feedback. We really do value your feedback. And in my remaining, whoops, sorry. I pressed something I wasn't supposed to. I don't know what I did. I'm just going to let that happen. Okay. In my remaining now 1 minute and 20 seconds, I do want to just actually take microphone's prerogative and follow up on some conversations from yesterday about approaches for justice-involved individuals and the relevance for implementation science. So last week, HRSA took new policy action to support HRSA-funded health centers in the provision of health services to individuals during the 90 days prior to their release from incarceration. And this is to help ensure continuity of care as people move home back to their communities. They also announced a new competitive funding opportunity for HRSA-funded health centers to implement approaches that focus on a number of areas, including preventing, screening, diagnosing, and treating hepatitis C, HIV, syphilis, and other infectious diseases, and also things like case management to address social determinants of health. So this funding opportunity is to build on existing evidence-based models to pilot innovative approaches. Sounds like implementation science to me. Applications are due June 10th, and it's open to currently funded HRSA health centers. So check out the HRSA website for more information if that might be of relevance to you. Look at the policy guidance. There's really interesting stuff in there. So as you can see, implementation science really is foundational to HRSA's work to end the HIV epidemic, and that really does only work in partnership with all of you. So thank you again for your time, and I'm now going to turn it over, I think, to our first speaker. Yes? Yes. All right. Thank you so much.
All right, hi everyone. Thank you for having me here today. It's been a wonderful conference so far. My name is Reva Datar. I'm a postdoctoral fellow from Johns Hopkins Bloomberg School of Public Health. And today I'm going to be talking to you about a study we're doing about strengthening community academic partnerships in HIV implementation science. I have no disclosures. And before I begin, I, of course, want to acknowledge our incredible advisory committee made up of community and academic partners, many of whom are here today, that are engaged in EHE awards. And they've all contributed their time and expertise to our study. I also want to acknowledge our team at the JHU CFAR, Dr. Laura Beres, who is the principal investigator of the study, as well as Drs. Cherie Schwartz, Stefan Barrel, and Greg Rosen, who are all co-investigators on the project, and Wilson Gomez, our data analyst. Our study is supported by NIH funds to our MAC Hub and the Tennessee CFAR, which supports our advisory committee. So since 2019, nearly 250 EHE Implementation Science Awards have been provided across the United States with the explicit goal of strengthening research community collaborations. Now, we all know from prior research that community-engaged research can help address social and structural determinants of health and reduce barriers to care within existing healthcare systems. However, more information is needed to really understand how we can optimally design, implement, and support community academic partnerships engaging in research. So to that end, our study really is seeking to advance research in this space. So our objective is to measure and describe successes and challenges in community-engaged research among academic and community-based partners engaged in EHE activities to improve opportunities for future collaborations. So this is an ongoing study, and we just completed AIM-1, in which we distributed an online survey to 2021 and 2022 EHE awardees, both community and academic partners, to better understand what meaningful engagement in community-engaged research activities actually means to awardees. Our next step is going to be to identify barriers and facilitators associated with meaningful engagement in community-engaged research, and we'll be doing that using semi-structured interviews. And finally, we will use best-worst scaling methods to identify key priorities associated with community-engaged research. So today, I'm really happy to share results from AIM-1 with you, and then discuss how our findings can inform the next stages of our research. Going to the next slide? Okay. So for the sake of time, I'm not going to go into great detail here, but I did want to outline the key measures included in our survey. So the first was level of community engagement, guided by the Continuum of Community Engagement model developed by Key and colleagues, which shows the spectrum of community involvement from none to community-driven or community-led. And we also measured partnership trust using the CDC Partnership Trust tool. We also assessed community involvement in the research process, as well as principles of community engagement. We adapted a validated tool by Goodman and colleagues for the engagement principles piece and focused on the 6 engagement principles that are shown here that include things like facilitate collaborative, equitable partnerships, and integrate and achieve a balance of all partners. So what did we find? So of the 102 possible EHE projects from 2021 and 2022, we received surveys for just over half. And of these, 41% included paired data, or surveys from both community partners and academic partners of the same project. So importantly, these surveys were completed independently. We received a total of 82 surveys, with approximately 2/3 completed by academics and the remaining third completed by community partners. Most of our participants were white females, and when we look at the median number of community academic partnerships prior to the EHE award, we can see that both community and academic partners in our sample had some prior experience working in these types of collaborations. All right, so now we'll look at the level of community engagement. So in our survey, we asked 2 questions. We asked, what level of community engagement did you expect to experience, and what level did you actually experience? So this graph is showing responses from the academic partner perspective, and along the bottom of the graph, we see the levels of community engagement, and they go from none to community-driven or led, so increasing from left to right. And the lines each correspond to a single survey respondent. The green circles show what level of engagement the respondent expected to experience, and the pink triangle shows the level they reported actually experiencing. And what we see here is that most academics, nearly 80% of them, reported expecting higher engagement than they actually experienced. And when we look at the same type of graph, displaying data from community partners only, we see kind of the opposite. We see that over 70% of community partners reported lower anticipated levels of engagement than they actually experienced. So we're going to use our AIM-2 interviews to better understand the meaning of these findings. So we also looked at average quality scores across each of the 6 principles of community engagement. So participants reported the quality with which each principle was implemented in their EHE project on a scale of 1 to 5, with 5 being excellent. So on the right, we see total scores across all respondents, and on the left, we see total scores among community and academic kind of separated out. And what we see is overall, all of the responses were quite high, and they were quite similar among academics and community partners. We also looked at community involvement in the research process. So this graph shows responses from both community and academic partners with specific research activities listed on the left-hand side. Respondents were asked whether community partners did not participate, consulted on, or actively engaged in each step. And respondents were able to mark NA if not applicable to their study. And what we saw is that high community engagement was reported for things like recruitment and data collection and intervention implementation, and lower engagement was reported in things that occur earlier in the stages of research. So things like grant writing, background research, and choosing research methods. So this is a similar graph, this time showing attributes of trust on the left-hand side. And what we see is that while receiving overall very high scores, those are in the blue, the trust components of power sharing, dependability, and clear communication actually received slightly lower scores. We also asked for open-ended responses to a question asking about other components of meaningful engagement that were not included in the survey. And from the responses received, emergent concepts included things like sociocultural responsiveness to intersecting identities of partner communities, intentionality, and study feasibility, with one community partner noting that academic partners often design unrealistic studies, and community partners are often burdened with fixing these studies. Funding challenges and administrative barriers were also noted as issues that are critical to meaningful engagement. So our results suggest that these awards have largely resulted in active, trustworthy collaborations from both the academic and the community partner perspective. However, there are still challenges in aligning expectations of engagement with actual implementation. It can also be a challenge to measure level of engagement because the terms that are commonly used in community engagement are often interpreted differently. So more work is needed to establish consistency in defining these terms. So as we continue with our study, we want to better understand how community partners want to be involved in the research process and what kinds of changes can be made to facilitate improved, meaningful engagement in projects funded through EHE awards. Strategies are needed to improve equity and power sharing, communication, and dependability among partners. And finally, that structural changes within the systems that facilitate these partnerships, such as feasible submission timelines and administrative support, are needed to more fairly recognize the important contributions of community partners and prevent placing additional burden on these organizations. And in the 10 seconds I have, as a quick concluding plug, I would love to invite all 2021 and 2022 EHE awardees here today to participate in the subsequent aims of our study. Your perspectives and experiences will really be critical to answering some of these very important questions. So thank you.
Buenos días.
Buenos días.
So I'm Mario Perez, and I have the honor of managing the response to multiple epidemics in LA County. I'm going to start with the key takeaways. So if I run out of time, I've covered my bases. Research to practice. We have to do things differently. We have to end multiple epidemics before we can end a singular HIV epidemic. We have to transform healthcare delivery systems and adapt to changes in healthcare consumption patterns. People consume healthcare differently, not the way we did, including young people. Those healthcare consumption patterns have to go beyond healthcare settings, and we cannot expect our target populations to adjust to the systems we put in place. We must start a 10-year national mental health, social worker, SUD specialist workforce recruitment, development, and training program. Let's think about Teach for America or the Peace Corps. HIV is increasingly concentrated among persons with mental health and substance use disorders. We do not have the capacity, the bandwidth, or the workforce to get the work done. We need more practitioners. We must change the way we collect data, use data. We have to have integrated surveillance systems, and we have to share data with frontline providers. We have a repository of data. We should share that for public health good, public health purposes. We have to do more of that. We have to relax our rules around data sharing. And we have to change how we finance things. We have to broaden the list of allowable expenses, contingency management, emergency financial assistance, guaranteed basic income. Those should be things that we support to end HIV. And we absolutely must coordinate the categorical investments we make across America at the state, local, and federal level. It's too siloed. Investments are being made in backyards with providers who are well-intentioned, but just don't have the capacity to get the work done. We know a couple of things about providers working in our backyard. And we have to push boundaries and disrupt dysfunctional systems of care if we're going to end this epidemic. None of this work gets done without a team, a village, so thank you to our UCLA partners, thank you to all the practitioners from LA County who are in the room, thank you to the EHE team who's mostly in that corner. Look at their faces and talk to them. They are really the brains and brawn behind these interventions. LA County has the second largest epidemic in America. We've got about almost 60,000 people living with HIV. We have about 4.64% of the national HIV prevalence, down from about 4.9%. We've got about 4.36% of the incident infections. I know this because these numbers have resulted in us getting a decrease in our National HIV Prevention Award. We have about 1,400 new infections. We diagnose about 1,500. We have to diagnose about 2,000 to 3,000 people if we're going to eat into the number of people who are undiagnosed in our county. We have our indicators like everyone else. 59,400 people estimated to be living with HIV, about almost 7,000 unaware. We believe that about 76,000 LA County residents are really good candidates for PrEP. Overwhelming majority are persons who are Black or brown. So we have our current performance benchmarks against our EHE targets. At this point, April 2024, we should be at less than 1,000 new HIV infections per year. We are not on pace to meet that goal. We have an STD crisis. Nearly 100,000 reported STDs, syphilis, gonorrhea, chlamydia. If we do not address the grossly uneven funding for STDs in America compared to many other things, we are not going to make progress. Increasingly, people diagnosed with syphilis, gonorrhea, or chlamydia are also co-infected with HIV. The numbers are clear, things are getting worse, we have to do better. So we have a county of about 4,000 square miles, 10 million people. We do planning around 8 service planning areas, on average about 1.25 million people per SPA. Really hard to do planning, so we also have health districts. There's 26 health districts that we use. And if you look at poverty, HIV, substance use disorder, syphilis, you have the same geographic patterns typically. So when we talk about doing work in LA, scale, scale, scale. We need 20 of everything. Congenital syphilis continues to be a crisis, but there are some intersections that, not surprising, 40% of congenital syphilis cases involve persons with unstable housing, a third with history of incarceration, 3/5 who report substance use, meth being the most common, and 2/3 with later no prenatal care. Interventions, particularly in this area, must go beyond the healthcare setting. The number of homeless, we're at over 67,000 homeless persons in LA County, a tragedy, a humanitarian crisis. Increasingly, people who are experiencing homeless are also being newly diagnosed with HIV. Those trends are going in the wrong direction. We have to make sure that HUD is at the 4th National EHE meeting next year. Among all the, 13% of all the new HIV diagnoses were among people experiencing homelessness. That's up. 20% were cisgender women. That's typically a 10% number. It's now 20%. Typically about 4% of new cases are among trans women. That's now at 11%. Meth is clearly a trend. The diagnosis of folks in hospital settings is really, really important. So we're trying to routinize as much as we can screening in hospitals. So I was looking at this slide that the team put together. It talks about moving from HIV research to practice. You know, are things feasible? Do they address disparities? Are they high impact? Are they scalable? Very, very important concept. So I'm like, well, from my perspective, how do we move from HIV research to practice in a large, populous, expensive metropolis with high levels of STIs, SUD, homelessness, income inequality, that leans on fragmented and uneven funding streams? The Department of Health Services, the Department of Public Health, Department of Mental Health, not one health department, 3. 95 hospitals, more than 100 FQHCs, CBOs, with varying levels of capacity, expertise, and interest. That's what we're facing in LA. So I added a few things to this. Will we marshal the resources? We made an investment nationally to support the CDC infrastructure, community-embedded DIS. It went away. Debt ceiling, negotiations. We eliminated an army of folks on the front lines in America doing critical DIS work. Will we coordinate investments, or will we continue to have a siloed approach to funding, and will we sustain it? Okay, so a few things from LA. 2 minutes. We have priority populations, so we focus a lot of energy here. We use the 4 pillars like everyone else, and each pillar has a robust number of strategies. We also have some cross-cutting strategies. For the diagnose pillar, we have a number of different testing modalities that we support. The HRSA, BIPIC, FQHC funding to routinize testing, very important, but we could have lent some coordination there to make that investment better. Testing resources are absolutely crucial for different messages for different audiences. For the treatment pillar, we're making some progress, not enough. We believe in contingency management. You heard from Reva and Wendy earlier, really focus on young people under 30 living with HIV, access it through a QR code, enroll. We have to make things easier. People will connect and consume differently than we were used to. Rapid and ready, let's get clinics who accept immediate appointments, part of our system. Let's do same-day ART. We have treatment hubs that we think are important. We have a lot of resources for people with HIV. There's been an angst to make sure that we have different information and access points for folks. We have a Dare to Care program where we're working with clinics to make sure that they're using our surveillance data to help find clients that they have previously served who've been lost to care. You have to have a data analyst to help look at the data with us, and you have to have clinic-embedded HIV engagement specialists who are pounding the pavement and helping get clients you used to see back into care. We have a number of prevention and PrEP indicators, a number of different modalities to access PrEP because everyone loves choices. We've got teleprep in our county-based public health STD clinics, so there's 9 there. There are also community-based PrEP centers of excellence that we support, and some of them also have long-acting injectable PrEP. Again, information is key. Teaching people how to do things is important. We are strong believers in public health detailing. You can't just take a concept and then make sure that someone is going to learn and know. So we do detailing to sit down with the practitioners and say, this is how you do it. This is a conversation. Here are the key points. So we think we've had a lot of success there. I'm going to skip through the PrEP slides. The respond pillar, we talked about this briefly yesterday. Cluster detection and outbreak response is absolutely crucial. We do not want an outbreak in our backyard. We also have a community health ambassador program where we're using cluster detection data, marrying that to social network, persons in social network to help penetrate the clusters, get people potentially diagnosed and linked to care. And we have an advisory board in response to some of the concerns that have been raised in the last few years. We have a community engagement program that's really centered around 8 community teams in EHE priority populations. Here's an idea of some of the stuff that they're doing. So the team that's focused on Black MSM, we're trying to address stigma of HIV and queer identity within faith-based institutions. For the trans and gender inclusive group, conference led by TGI community has been important. We have a number of cross-cutting strategies, a lot of different intervention grants. We're trying to fund things outside of the health department through a third-party administrator to have the resources hit the streets really quickly. We have a number of action kits that we think are really valuable tools that cover soup to nuts, whatever it is, tied to that intervention. And we have, this is my last slide. So we have a number of critical partners tied to this EHE crisis. And a number of them are in the room today, but frontline service providers, clearly, we are asking a lot of you. Our academic partners, we gotta make sure that we do a better job taking your randomized control trial information and translating it into programs. Okay, not everyone's doing an RCT, but you get the point. We got policy partners who need to help us drive better policy, community engagement, healthcare financing partners. CMS should also be in this room next year. Right. There's too many things where CMS dictates how we finance things, and those financing schema are not always in line with us getting work done. And we have advisory groups. So for our partners at HRSA, we have to reauthorize the Right and White program. It's not allowing us to optimize our impact locally. And if you're at the Bureau of Primary Health Care, work with us to influence how we get the FQHC network to do a better job. CDC partners, we have very uneven funding across the multiple centers, including the Division of STD Prevention. We have to change that. $174.3 million in America is laughable for an STD control response. NIH, every dollar of research, 80 cents for research, 20 cents to translate the research into practice. Indian Health Service, Rick, you just need more money. SAMHSA, we need a 5% STD set aside, like we had an HIV set aside for years, to really undergird the STD control crisis in America. And our PACE team, thank you for all your work. You gotta bring those federal partners to the meeting next year. Thanks.
Good morning. My name is Leroy Blay. I use he, him, and his pronouns, and I'm going to be and I'm the Ending the Epidemics project manager with the California Department of Public Health Office of AIDS. I'm going to be talking about California's EHE efforts and how this work was important to the subsequent development of our integrated strategic plan and implementation blueprint, and how that work now is the context of our EHE work going forward. My short remarks today are representing the work of many. I wanted to first recognize the community members that volunteered their time to review and improve our EHE plans and just convened with us in conversations and roundtables, even before things were written. They didn't get paid for it, but they actually showed up and actually really improved the process overall and continue to do so. I especially want to thank our California Planning Group and the members of the HIV planning groups across the state that continue to engage with us throughout the implementation of this work. I also wanted to recognize the work of Dr. Mercer Ramos and Dr. Kathleen Jacobson and their teams, who are my coworkers, who have been heading the implementation of this work really related to this strategic plan, both in the Office of AIDS and the STD control branch. And I also wanted to thank our EHE coordinating teams of each of our California consortium counties. And they're represented here today. They are Alameda, Orange County, Riverside, Sacramento, San Bernardino, and San Diego. Their work is impressive under really difficult circumstances, but the punchline is we didn't reach enough people and we didn't reach enough of the right people. So we need to continue to mature our EHE interventions in California and really think closely about how we proceed with partnering with our research partners and think about leaning into not just building our testing and prep programs, but thinking about a whole set of supportive services and a model that surrounds those programs and actually really invites those people into, invites our clients, invites our partners, invites our community members into those interventions. So I'm going to talk about the developments and next steps of this work, and I invite you to provide input to our process here, and we're going to have a breakout session. You're going to have a chance to meet or talk to some folks that are in the room that worked on the local parts of the implementing our EHE plans in our various counties. So that was a long introduction, but I have a short slide deck. So our California consortium really was, CDPH organized the response for 6 of our 8 phase 1 EHE counties in California. We did it because we knew that the work that was necessary to implement EHE in California was difficult and that a lot of our counties were stressed to the max, even before COVID came about. So we hired a consultant to assist us with community engagement. We leveraged existing planning council tables, and what developed as a result of the work and leveraging of a lot of existing resources and partners were a rapid assessment process that told the story of HIV in each of these 6 phase 1 each of these 6 EHE counties, and that we also got a plan on how to accelerate, in ideal conditions, the end of the HIV epidemic in their communities. A little bit of history, because of the context of our EHE planning, is now our strategic plan and implementation blueprint. California's first Getting to Zero plan was in response to the national HIV/AIDS strategy that called for an integration of HIV prevention, care, and surveillance efforts. This was in operation from 2017 to 2021. We made a lot of progress. You heard of that progress because we can focus on like the group of individuals that don't do well with standard or basic programs or standard health care. But because of this plan and work and making a significant progress, we know that it is not enough for all communities, especially Black, African American, and Latinx communities in California. So in response to the need to accelerate the progress of Getting to Zero, the Ending the HIV Epidemic initiative came about, and learning from that planning and context, when it came time to create a new integrated plan in California, California decided to level up, actually just to listen to community members, and to start to address HIV not as a condition on its own, but as a condition with hepatitis, as a syndemic, with hepatitis C and STIs through a social determinants of health lens. This decision was due to the input of many stakeholders and communities that were already leading in this area, many of which are in this room, so we appreciate that. And your input helped us to create a subsequent implementation blueprint that helps us drill down into the 30 strategies that are located on our Ending the Epidemics plan. Our Ending the Epidemics plan is a multi-county collaboration, much like our EHE plans are. We recruited the partners that are co-authors to the plan. It's a syndemic focus through social determinants of health lens, but we really want it to be a compelling document, a short document, kind of a slick document to be able to recruit partners to a wider set of collaborators that we knew we needed help with to actually achieve the goals of dealing more directly with social determinants of health. So this is an opportunity for us to have a collective impact, to do more than we could do alone, and we are constantly relying on the kindness of strangers. And we've learned a lot by being here, and if you have suggestions for the ways that we can proceed in California, if you see an obvious omission that we need to address, please come up to us, please give us help, and we can help you with our experience. And I've really appreciated the humility that people have approached their findings and their talks in this room, because this is a perfection-free zone. I don't think that as many years as I've actually worked in HIV prevention, getting to this point, which is being able to talk about getting to zero in terms of a syndemic and an HIV, the end of HIV, is an amazing point. But there is not enough investment in this moment. And I think of the EHE plans that we created as a tree that we plopped right down in the middle of the desert. without a sense of water and fertilizer and the things that we would need to actually make this thing grow. And it's a good idea. Many of the ideas that we proposed were good ideas, but there's not enough surrounding the implementation and the care and feeding of this tree to actually make those interventions go forward. So we're being much more humble about how we proceed and thinking about turning some of these projects into kind of getting back to basics in how we proceed with developing the PrEP networks, et cetera, in the counties that we're serving. I just wanted to note that we took this strategic plan on the road, and we did a lot of community engagement. Much of the community engagement that we weren't able to do in our initial EHE planning because of COVID. And in the interest of time, I'm just going to zoom forward. What we developed was an implementation blueprint that helps us drill down into our 30 strategies. We've talked a lot about this for a long time over the course of the last couple years. We did a roadshow throughout California. There's a lot of recordings of this online. Just kind of visit the website at the California Department of Public Health Office of AIDS. We have some special websites set aside that have a lot of recordings of some technical assistance, meetings that happened that give you a sense of what our implementation blueprint and our strategic plan are and how that context of nesting EHE there will help us. But I want to talk about our strategy partners, just to note that we have them, and you are included in those research partners. But we definitely think of the idea of addressing social determinants of health requires us, as Mario alluded to, bringing partners in that have control of resources that are outside of public health. And so we see here the list of strategic partners that are actually mentioned in our plan and have negotiated relationships to participate in our ending this endemic work. Going to the outcomes of our EHE interventions at a very high level, we had an increase in mobile services deployed to parts and counties that lack services infrastructure. We had a lot of brick and mortar collaborations that started. Some ended because of COVID. We assessed the readiness for counties to incorporate street medicine into the work that they do, which is much different than mobile services. It doesn't really belong there. But if you have interest in any of those things, please come and talk to us, and we'll give you more of a detail of how that happened. We expanded testing, expanded PrEP networks. We leaned into the Pillar 4 and did some very interesting things with data to care. Our data to care team at the state level does some really interesting CDR work that has helped counties and we've also have a cornerstone project in collaboration with Los Angeles to have a community advisory board to connect with a lot of concerns about CDR ahead of the game and to actually get input directly from community. I want to just go to the next slide because I'm over by 15 seconds. But I will note this. One of our most mature interventions has been our Building Healthy Online Communities Take Me Home program. It was the thing that we were able to implement even in the spite of COVID. And through that program, we've seen over 4,000 individuals. We have ordered tests. We've expanded that program. That is integrated testing. And we've expanded the ORQUIC component of that testing to every jurisdiction in California so that a resident in any jurisdiction in California can, through a dating website or through the link that we have for the program, order a test for themselves or for a drug-using or sexual health partner. So please help us promote that program. There are plenty of resources there. As for next steps, what I want to say that we want to focus on for what happens next is that we want to continue to document the successes of interventions linked to priority populations. My punchline was the very first thing that I said, so I'm going to repeat that. We want continued community engagement and collaboration and link directly to improving interventions. We've done a lot of general community engagement and we want using lessons learned from you all, but to have community engagement connected to each one of our interventions. We want to support the piloting of more and more interventions, taking on the evidence-based models in collaboration with their testing and PrEP programs that were created in our counties. And then we want to continue to share best practices across regions. And we have a variety of ways of doing that, but in the interest of time, I'm going to end there. Thank you very much for your attention.
Thank you so much to our panelists. Those were excellent presentations. I think that we have 5 minutes for a few questions, and what you don't get to answer here, we will have a breakout session in the Legacy Room, I think, at 1:15. So questions for our panelists?
Hi, I'm Sean Pleasants with the UCLA-CDU CFAR CAP. My question, well, first of all, I want to say I'm very excited to see all these projects and the work that you're doing. However, I would like to see more mental health integrated into these different programs. As someone living with HIV who was homeless over 10 years and experiencing active addiction, mental health was very important, and it made me feel as if I didn't deserve treatment. I think we need to realize that wherever there's HIV, there's a mental health issue probably going on as well. And in my case, it was worse than the HIV. So I also want to say that care should probably not just be an afterthought or a little module you add on, but can we integrate it into everything we do?
Right.
Because this is about health.
Yes.
Thank you.
I didn't know if anybody wanted to comment, but yes, I agree strongly. As a clinical psychologist, I highly agree. Did you, Mara, you mentioned that the mental health workforce. Did you want to make any comments? Or?
Yeah, you know, we need more practitioners to do the work. We have investments that often go unused because our partners cannot hire their personnel to do the work. And so that's why I'm a strong advocate for a different training program to address mental health, SUD. Social workers play a more and more prominent role in some of our street medicine interventions. They have an important skill set as well. So we need the whole rubric of practitioners. We gotta do things differently.
Thank you.
Hi, everyone. I'm Laura Mintz. My pronouns are they and them. I'm from Case Western Reserve in Cleveland, Ohio. This question is for all of you, but particularly for Dr. Perez. So harm reduction saved my life when I was a teenager in the mid-90s. Et cetera. I graduated from residency in 2015, and I'm here now. And so I made the transition from being a community member to a researcher. I think you get a doctorate and then you're not in the community. Anyway, but I think I'm saying this to say I've been around for a long time, and I know many of you have, and I've been observing in this conference that I feel like I had this conversation 25 years ago, like every single one of the themes. Things have changed, obviously, it is extraordinary, but the things that you are advocating for in terms of bringing those federal partnerships, I wonder about not only bringing these folks to the meeting next year, but what can all of us who have a couple hundred doctorates in the room, what can we do to advocate those systems together before we have another meeting where we say the same thing?
Thank you.
Yeah, so I'm not a doctor, but I play one on TV. So, you know, I think if the message resonates, then let's message multiply. And we know who the audience members are, and perhaps that could change the trajectory of our response. I think being really honest about the limited progress we've made since 2020 is really important, and how far we are from our 2030 national EHE goals is also important. And if we're serious about meeting these goals, then we have to compel our partners at the local, state, and federal level, not just at the federal level, and policymakers to support us doing things differently.
Thank you. Last question. Thank you.
Yeah, Tom Bellin from the Methods Core of CHIPTS and the UCLA-CDU Center. I was just maybe to elaborate on some of those points. If you had, there were a number of references to expanding STI programs and earmarking funding, and I was just thinking it might be helpful if you had that additional funding, what would be the sets of actions that you would take with the funding? How would that unfold?
Sure. So 20 years ago, maybe longer, there was a rule that said for every state SAMHSA block grant, sizable grants to states, 5% had to be set aside for HIV-related programming, given the very clear nexus between HIV and substance use and mental illness. we have to pivot. The sexual health crisis is tied to substance use disorder. It's tied to undiagnosed, untreated mental illness. The intersection couldn't be more clear. Every person going to substance use disorder treatment should be screened. There should be a full sexual health, a full physical. The number of places where folks can get STDs screened, diagnosed, and treated, there's far too few. It's a syndemic approach to the work, and I think that if state health departments and local jurisdictions had a significant increase in dedicated STD sexual health resources, we could make a dent on the things that, quite frankly, are also driving new HIV transmissions. So it's all interconnected in my mind, but I think an STD set aside to the SAMHSA block grant would be an immediate infusion of a substantial amount of cash. And as you heard from the last panel, cash is king.
Great. Thank you. We're out of time. Why don't we have a final round of applause for our panelists? And I want to invite everyone to come to our follow-up session at 1:15 in Legacy Room. Thank you.